All right, so we have a lot to go over today. Okay, so let's talk about our antidysrhythmic agents. So I want you to think of these as opposite of heart blocks, okay? Because we're using antidysrhythmics because the heart is fast, right? So the heart is acting up. It's an AFib, RVR, right? VFib, VTAC, A-flutter, SVT. So now we have a really fast rhythm and we're using antidysrhythmics to treat the fast rhythm. Because we're using antidysrhythmics to treat the fast rhythm, these antidysrhythmics, once we're using them and they slow down the heart, can put the patient into a heart block. So remember we talked about the classes of heart block, like class 1, class 2, like 1 and 2, and then class 3. So, types of heart blocks. Remember we said you have to look for the offending agent and stop the offending agent. Guess what? Your antidysrhythmics are the offending agents. So they're almost opposite. So if you have somebody that's in a heart block, you're looking to see if they're on any of these antidysrhythmics that could have put them into a heart block because we want to stop it. If the heart's really fast, AFib, A-flutter, RVR, SVT, VFib, VTAC, we're going to give these antidysrhythmics to slow down the heart. So I think Kara asked a question a few minutes ago about, do you really need to know what class of drug they're from? No, but I want to point out something, and this is why I write this on here, is so look at class 1A, slows conduction, prolongs repolarization of the QT. So it prolongs the repolarization, prolongs the QT, okay? So it's gonna slow conduction, okay, class 1B, slows repolarization, decreases ventricular excitability. Class 1C, slows conduction, prolongs QT, right? Class 2, slows AV conduction and contractility. It's a negative inotrope, right? So we're talking about beta blockers. Remember, we have positive inotropes, which is going to increase contractility. Negative inotropes, which include beta blockers, it blocks that beta 1. So negative slows it down. Class 3, prolongs QRS and repolarization. Class 4, decreases myocardial contractility, blocks calcium influx, delays AV node conduction. So do you see how giving all of these drugs, because it slows everything down, can put your patient into a heart block? So you would never, ever, ever give these drugs if your patient was bradycardic or in a heart block, because you're going to stop the heart because you're slowing or delaying conduction through the AV node, through the ventricles. Okay. So they're almost opposite. So if you have somebody in a heart block, you're looking for these drugs because you got to stop them. If you have somebody in a fast rhythm, you're looking for these drugs because you got to start them. Okay. So I don't think it's so important to know what class they're from, other than knowing that we're trying to treat a dysrhythmia that's in a really fast rhythm. Okay. So overall, class 1 agents, we're trying to improve cardiac output, decrease ectopy or AFib, side effects. So if we're slowing it down, right, if every single one of these drugs is slowing down the conduction or slowing the electricity through the AV node or slowing repolarization, guess what's going to happen? They could become bradycardic. They could go into heart failure. They could have dizziness, headache, lightheadedness, right? Because we're slowing everything down. Okay. So almost everybody's going to could have that bradycardic. Like if you give these medications, one of the side effects could be what they experience when they're in a heart block. What do they experience when they're in a heart block? Well, they have a headache. They might be dizzy. They might have chest pain. They might be short of breath. They might have syncope, right? Because we slow everything so slow. Well, if we give these drugs and we slow everything down, they can have the same effects as if they're in a heart block. Okay. So hopefully that helps you guys make the connection. So why are we using some of these 1A agents? Well, we're looking for something fast. So SVT, PVCs, and tachydysrhythmia. So something fast. This is your Norpace, your quinidine, your procanamide. So those are your big drugs that you'll see in the class 1 agents. What do you worry about? Bradycardia, hypotension. Don't go crazy. We just know it's slowing it down. So it can be hypotensive, bradycardic. Okay. Class 1B, slows repolarization. Why do we give these? Fast things. So PVC, pre-ventricular contraction. So the beat's coming early. So it's fast. So PVCs make the rhythm faster. PACs make the rhythm faster because they're coming early. They're coming too fast, right? So PVCs, VTAC, VFib, our drug is lidocaine. You usually only see this given in the ICU. We would only give this through an IV. So what do we worry about with lidocaine? Well, guess what? It slows it down. It numbs it. It's like Novocaine or something like that. What do you go to the dentist? They give you Novocaine, numb your mouth. Same thing. This kind of numbs the ventricle and it makes it not as excitable. So it just decreases that irritability to the ventricle. So we use lidocaine almost always in like V-fib or V-tac. And we worry about numbness, of course. Think about it. So if it's numbing the area, it's affecting the nerves. So what are your side effects? We'll look for something that affects the nerves. Numbness, twitching, tingling. They can have convulsions. They can get confused. Guess what? Bradycardia, hypotension, right? We're slowing it down. And then they can end up dizzy, lightheaded, respiratory depression. Okay, so slow it down. Class 1C antidysrhythmics, slows conduction, prolongs the QT. Why do we use it? Something fast, VTAC, VFib, AFib, A-flutter, SVT, Wolff-Parkinson-White syndrome. I think of like flecainide or Rhythmol or Tambacor. These are the drugs that we use to treat refractory AFib. So a lot of these have to be ordered by a electrophysiologist, because you remember first line for AFib is your calcium channel blockers, right? Any provider can order that. You could be a cardiologist, you could be a primary care doctor, you could order that. But once we start to see that calcium channel blockers like cardizem or diltiazem doesn't work, now we have to go to the big guns. Well, now we have to have somebody that specializes in the electricity of the heart, right? So a lot of times they have to be ordered by an electrophysiologist, and these are for refractory AFib. These are for patients that really do not respond to first line therapy, okay? Class 2 agents, again, we slow. It's a negative inotrope, so it's opposite of your positive inotropes, right? So that would be like opposite of dopamine or Dobutrex, right? So here's your beta blockers: esmolol, propanolol, acebutolol, sotalol. And sotalol you'll see crosses over because it falls into 2 drug classes. But a lot of these are not cardiac selective. So we have to be super careful, because now it's not just affecting your cardiac and beta 1, but it might affect beta 2. So you've got to look at those COPD, asthma, respiratory patients, make sure that they don't have bronchospasms, because what does beta 2 do? Help you breathe and bronchodilates. So if we block beta 2 with these non-selective cardiac meds, then guess what's going to happen? They can actually have bronchospasms. So we have to watch for that, right? We should see the heart rate come down, right? We're blocking beta 1, so we should see the heart rate come down. The blood pressure should drop. We have an improved cardiac outload because we're decreasing chest pain and we're decreasing the workload of the heart. But if we slow it down, what are we gonna have? Bradycardia, hypotension. They can have edema because fluid could back up, fatigue, heart failure, dizzy, right? The same symptoms. If our heart rate goes from 110 to 60, could those patients be lightheaded, dizzy, and become bradycardic or hypotensive? Of course. Okay. So remember, watch for the bronchospasm if they're not cardiac selective drugs. Okay. Class 3 agents, prolongs QRS, so slows it down, and repolarization. Big drug, amiodarone. You guys that are on PCC, how many people have given amiodarone? We've been giving it, and I've only been there a couple weeks. Those open heart patients, you guys giving amiodarone PO?
No, I gave it through an IV.
Okay, gave it IV. Okay, you could give it PO or IV. But the wonderful thing about amiodarone is it is one of the only drugs that is FDA approved to treat the atria and the ventricular dysrhythmias. So it's a wonderful drug. It just has a lot of side effects. So after open heart surgery, when we're like tying these little vessels all over and rerouting the blood, is the heart irritable? Could they go into these dysrhythmias very easily? Of course. Now we've rerouted blood flow. We might have hit some of the areas where the conduction happens. So a lot of times they put them on amiodarone coming right out of OR. They might put them on an amiodarone drip, and then we start them on oral amiodarone to prevent them from having dysrhythmias. So it's the drug of choice for atrial and ventricular dysrhythmias, prolongs QRS, prolongs repolarization, so it slows it down. There's a lot of side effects. You got to know these side effects, guys, because it's a big deal. Thyroid, okay, could cause thyroid toxicosis. We have to check the TSH. Cornea, in long-term use, they can actually have corneal deposits, and they can have like a halo on their vision. So they might have to see an ophthalmologist or an eye doctor. Pulmonary toxicosis, it causes fibrosis. Well, you guys know what fibrosis does. It turns into ARDS. It makes the lungs hard. So they might have to see a pulmonologist to get PFTs and make sure their lungs are functioning. It can increase the level of coumadin and digoxin. So we have to make sure we're monitoring their PTINR and their digoxin level. And these patients that are on our long-term can end up with this blue-gray discoloration of the skin. So some things that we have to educate our patients about and making sure that they follow up with their provider and get scheduled for all of these testing if they're going to be on it long-term. I don't know that the open heart patients are on it usually long-term. It might be just a couple, like 4 to 6 weeks after surgery. And then they start to wean them off of it. Again, remember I talked about sotalol. Sotalol is considered a class 2 because of the beta blocker properties, but can also be considered an antidysrhythmic in class 3 agents because it, when these patients go on the sotalol, it actually slows down conduction in a little bit of a different way than just a beta blocker would. So a lot of times they have to be on a monitor for a couple days, or we do EKGs to make sure that we don't slow it down too much and widen out that QRS. Okay. Tikasin, class 3 agents. These patients must be in the hospital for 3 days after we start Tikasin. They have to have an EKG with each dose. And if the QTC is greater than 500, they're more likely to go into torsades de pointe. So we have to make sure that we have them and we're doing EKGs before they get the dose. I think last summer, I might've had some of you guys on clinical on 7 West Extension. And one of the nurses came up to me and she's like, hey, I'm about to go give this drug. And I was like, did you do an EKG yet? It was Tikasin. And she's like, no, I haven't. And she's like, but the last one was okay. And I said, well, I would do an EKG. I just would do it. She went and did the EKG. The QTC was 575. I said, I would not give that drug. I'd call the cardiologist. They're going to change the dose. And sure enough, that's exactly what happened. And she was an agency nurse and she hadn't worked on a cardiac unit for a while. And she's like, thank goodness I asked you. I said, everybody has their own guardian angel for whatever reason. Like, you know, we were just meant to talk at that time. But because what happens is, so think about your PQRST. So if you have your P, your QRST, if your QT starts to widen, right? If it's prolonged and delayed, guess what it looks like? Torsades de pointe. It's like small, small, big, big, wide, small, small, big. So it starts to widen out and they can go into torsades de pointe or VTAC. Okay, so big deal. If you slow conduction too much, now we have to worry about that QRS widening out, conduction's delayed too far, and now we don't have good repolarization. Okay, we can have the Corvert or the multi-tac. You don't give that with heart failure. If they have Tikasin, they have to avoid Tagament. But why do we use these drugs? These are some heavy duty, high risk drugs. So most often we use them for AFib, A-flutter, VTAC, and VFib. We should see an improved cardiac output. Even though they slow conduction, we have better vital signs because it makes the heart work smarter, not harder. Remember, we're really fast. So if the heart's like ding, 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 do we have good cardiac output? We might be okay, but the heart's working really hard to make good cardiac output. So if we slow it down, we have more time to actually allow the ventricles to fill, better contraction when they do beat. It should decrease chest pain because it's decreasing myocardial workload. It should decrease their fatigue. And we use these drugs when other drugs fail. So if we've tried other antidysrhythmics or we've tried other medications to control the AFib or PVCs or VTAC, and they fail, then we go to these drugs. So they're not usually used first line. Side effects, bradycardia. They can have headaches, fatigue, and of course, torsades de pointe because we slow everything down too much sometimes. Class 4, decreases myocardial contractility. These are calcium channel blockers. I don't even need to tell you what they do. Everybody by this point should know what a calcium channel blocker does. We use it for SVT or AFib, A-flutter. It's first line. So what are we doing? We're looking for an improved cardiac output. We're looking for reduced chest pain and fatigue, better vital signs. What happens if you give calcium channel blockers? They can become bradycardic, heart failure, hypotensive, and they can go into a heart block and become asystole. Okay. So let me give you a couple more notes about this. So antidysrhythmics, they treat cardiac conduction disturbances. Remember, sometimes when we talk about, I just gave you a little picture, calcium lives outside, potassium lives inside, sodium lives outside. So we see an exchange, which activates the cell. When calcium goes in the cell, it activates the cell. And then just a reminder about your depolarization and repolarization and when things happen within the isoelectric line. So on the P wave, the atria depolarize. And then the QRS is when the ventricles depolarize. And then on the T wave is when the ventricles repolarize. And if you look here, the atria repolarize during ventricular depolarization. So the atria depolarize here and they actually repolarize here. But because of the ventricle depolarization, you don't actually see it on the isoelectric line here, but it's actually happening. It's just hidden because ventricle contraction is so much stronger than atrial relaxation. Okay.
I have a question.
Yeah.
So with torsades, that's with a prolonged QT and like QTC, is that just like a different?
Yeah, it's a more specific measurement of that QT interval.
Okay.
So the QT is you're measuring the QT on the line with the small boxes, but the QTC is actually a measurement in so many seconds of, and you can only, so a QT you can get on your regular rhythm strips, but a QTC you must get on an EKG.
Okay, so that happens with the prolonged QT. So that's saying the ventricle is taking longer to relax, and that's why you would give magnesium.
Depolarize and repolarize. It's so QT, remember, it's QRS and T, so it's depolarization and repolarization. So if it takes a long time to depolarize and repolarize, then that means it slows that conduction part of the cardiac cycle, and they could go into torsades de pointe. And if I bring you guys back up to this picture, you see if I have somebody that like it prolongs the QRS and repolarization, if this just keeps widening and widening because it's taking so long, because the medications is taking so long to depolarize and repolarize, you're going to see it widen and it looks just like torsades de pointe, just like it.
Because I was just confused because if magnesium relaxes, doesn't that normally make things slower? So then it would.
So magnesium doesn't slow things necessarily. It relaxes the muscle.
Okay,
so if you go into torsades de pointe, now this muscle is just fluttering. It's just flapping, flapping, flapping. So if we give magnesium, we stop that muscle from like flapping like this, and we can allow normal conduction to take place.
Okay, thanks.
It stops the muscle from being so hyperactive. Does that help? Do you understand that a little bit better?
Yes, thank you.
Sure. Any other questions before we move on? Those are antidysrhythmics. That's it.
I typed a question.
Yeah. Oh, so just pause and say the question because I have you guys over to the side, so I can't see your questions. I'm sorry, or comments.
That's okay. So like we have on our conduction concept map, and then we have VTAC, and then you said VTAC with a pulse. But we can also use it for VTAC, VFib. So I was just thinking like on the concept map, if I want to go back and study these, could I add lidocaine to the VTAC without a pulse and to the VFib?
Yeah. It's usually just not first line.
Oh, okay.
Yeah. Mm-hmm. Yeah. Most of the time when we're using lidocaine, it's with a pulse. The patients will be put on a lidocaine drip, but you can use it for both. It's just provider preference. Just knowing that just know that lidocaine is used very often for VFib and VTAC. It's for ventricular dysrhythmias, which is why when you go back to your concept map that we studied before about VFib and VTAC, lidocaine is one of the drugs that you could use.
Right. Okay. Thank you.
Mm-hmm. Okay. So rule of thumb, right? I said this in the beginning. We do not give our antidysrhythmics if the patient's in a heart block or a bundle branch block, or if they're in cardiogenic shock or sick sinus syndrome. That makes sense, right? We're not going to, those issues, that means that the heart's already blocked and slow. So we don't want to do that. We have to monitor our electrolytes. Remember, a lot of them you can't give with grapefruit juice. And I know probably some of you guys think like, well, how do we know? We studied grapefruit juice. But so in the 80s, I don't know if any of you guys that are old enough that you remember the 80s and maybe early 90s, everybody went on these cabbage soup diets and grapefruit diets, right? They were like grapefruit for breakfast and dinner with a cabbage soup, with this tomato cabbage soup diet. And that's how they found out, all these patients were eating grapefruit, and then they found out it was interfering with the medicine. It doesn't mean that initially when they started all these antidysrhythmics, they tested them against grapefruit, but patients had, you can see these waves and people following, like, now everybody's trying to go gluten-free and decrease carbs, so these waves of dietary changes, they found out that grapefruit really interferes with a lot of the cardiac medications, especially antidysrhythmics. Careful with erythromycins, and then careful with your anti-lipids. So just a kind of a general statement about some of the medications that interfere with these antidysrhythmics. So adenosine or adenocard slows conduction. We use this a lot for patients in SVT, and this is one of the only drugs you'll ever give super fast. So we give this over like as fast as you could push it. We've pushed it before at St. Joe's with students, and I gave them 6 milligrams, and they both students pushed at the same time through 2 separate IV sites and rapidly flushed afterwards. So the reason we have to do it so quickly is because it has a very short half-life, like less than 10 seconds. So what is our goal? Well, the patient's heart rate is SVT. Well, sometimes we have a hard time telling if the patient's an SVT or AFib RVR. So if you're an AFib RVR, adenosine is not going to work. But if you're an SVT, adenosine will work well. So we give it, first thing we want to do is have our patient vagal down. So if their heart rate's really fast, we want to have them bear down. Well, students or patients are like, what does that mean? Well, I usually tell patients, if you're a woman and you've delivered a baby, you want to push like you're delivering a baby. If you're a man and you've never had a baby, then you want to push like you're taking the biggest dump of your life. You want to bear down like you are taking the biggest dump of your life, right? And that will promote that vagal activity. So we ask them to vagal first, and then we give 6 milligrams. And if that doesn't work, we give 12 milligrams, and we give 12 milligrams. And if that doesn't work, then they're probably not an SVT. They're probably an AFib RVR, and we need to go look at our antidysrhythmics for atrial fibrillation, like cardizem or amiodarone, right? Or some of those higher, more invasive drugs. We have to have the crash cart at the bedside if we're going to give adenosine, because and you have to tell the patients, I've given this, and patients say it is the weirdest feeling because their heart literally stops and it feels like a long time. You'll see the heart stop and there's a huge pause and you're like, please start beating. Please, sometimes it can be up to 10 seconds because we're waiting for that half-life of the drug to exit the body. So it could be like a long time, so you have to have the crash cart, because in the event that the patient's heart would not start again, we need to start our ACLS protocol. But the patients will feel funny. Their heart's like this, ding, 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 ding. Nothing. So they go from this rapidly anxiety feeling to like everything slows down and kind of stops. Magnesium, of course, we've talked about that numerous times, especially with Lee yesterday. Treatment of choice for torsades de pointe. It decreases dysrhythmias in the atrial and the ventricles. We give remember we talked about this yesterday, 1 to 2 grams over 1 to 2 minutes if you're using it for torsades or anti-dysrhythmia. And then a lot of times we have to, if the MAG is already low, we give the 1 to 2 grams over 1 to 2 minutes to treat the torsades or the dysrhythmia, but then we have to start them on a MAG drip, because guess what's going to happen? That MAG is going to be used up and they still might be hypomagnesium. Okay. Digoxin, you guys know that's a positive inotrope. It slows conduction. IV and PO, make sure you monitor your dig levels. If your potassium is low, the patient could be dig toxic. So the reason that works is because digoxin and potassium bind to the same ATP site. So this is why I'm like, cellular level is so important. It binds to the same ATP site on the cell. So if you, and that's what activates the medication. So if you are low in potassium, guess what? There are more sites for dig to attach to activate the digoxin. So if you're low potassium, guess what? Now the dig is like, sweet, I got all these spots that I could attach to activate my medication. So the patients can become dig toxic if we're hypokalemic, really important. We use it for SVT, AFib, A-flutter, so supraventricular tachycardias. It does have the inotropic effect. No dig. I am telling you that you will get a question on dig on either this exam or the final. I promise you, you will get it on boards. So no dig, know the side effects of dig. I know you guys have learned dig before, so I don't write all that on here, but just like your lab values that you've learned before, go back and look at dig, look at the side effects of dig, look at the things you have to worry about if you're going to give dig, because that's important to know. Okay. Cardioversion, your patient has a pulse, right? So we might cardiovert somebody that's an AFib or A-flutter with a fast rhythm, or we might cardiovert somebody with ventricular tachycardia with a pulse. the patient's awake and they're conscious, and we might give some conscious sedation, maybe like some Valium or Versed to kind of calm them down. We attach the same paddles that we would for defibrillation, but we use a lower jolt. Okay, so we put them on the monitor, we use lower jolts, and we sync it with their normal rhythm because they actually have conduction. So we don't want to shock them in their own conduction cycle. We want to shock them and try to get them back into a normal cycle and get them out of that VTAC or AFib or A-flutter, right? You need a consent. Okay, we can do this at the bedside. Oh my gosh, I remember my first time doing it on PCC. I was like a nurse for a year, and I was like so scared that they were just going to stop the heart. But if your patient's been an AFib or A-flutter for a long time, even VTAC, a lot of times we might have to do a TEE first or give heparin, because remember, when they're in AFib and A-flutter, what's happening? The heart's just mildly shaking at the top, or like quivering at the top. So blood is not circulating through the heart as rapidly or as well as it should be. So if blood sits anywhere in the body, it has a higher likelihood that it could clot. So if your patient's been in AFib for a week or two and they didn't know it and they come in, could they have developed a clot? Yeah. If we shock them, what are we going to do? We're going to shove that clot right through the ventricle into the aorta and give the patient a stroke. It's going to hit one of those vessels off the top and they're going to stroke. So a lot of times we might have to heparinize them first, or we do a transesophageal echocardiogram to look to see if there's any clots on the back of the heart. Okay. For cardioversion, the patient has a pulse, it's controlled, we sync it with their normal rhythm. We might give some mild conscious sedation to relax them because we're going to shock them through the chest, not like a defibrillator, but we're going to give a lower voltage shock through the chest. And then we have to worry about clotting. We want to make sure we don't give them a stroke. Defibrillation is easy. VFib, defib. VTAC with no pulse, defibrillator. That is the only way you're going to save your patient. Okay, so defibrillation is the treatment of choice. It is the priority for somebody that's in pulseless VTAC or VFib. Okay, we give 3 shocks, sometimes 200, 300, then 360. If we shock after that, it's always 360. We start at 200, we go to 300, we go to 360, any shock after that. This is emergency. So your patient has no cardiac output. So this is, your patient goes into VFib, you go in, you check your patient, you always assess the patient first. You find out that they're in VFib, they have no pulse, you start CPR, use the crash cart. As soon as the defibrillator gets there, as you're doing CPR, somebody's attaching those electrodes because we need to shock them sooner than later. I'm clear, you're clear, shock, let's go. Start CPR again. Ablation, we use this a lot for AFib and A-flutter. This is where we have that electricity that's kind of irritating the muscle, and there's some kind of trigger within that cardiac muscle or the tissue that keeps triggering this AFib or A-flutter. So they can actually have an ablation where they go in, it's almost like they cauterize the area of the heart. But it's usually not first line. They'll usually try to control with medication first. And then the difference between your BLS and your ACLS, you guys all have your BLS. You have to be a nursing student. This is your basic life support. You know how to do CPR. Compressions are 100 to 120 times per minute, 2 inches deep, 10 seconds to check a breath. We shouldn't take longer than 10 seconds to check to see if the patient has a breath. If you can't find it, they probably don't have it. Okay. And then your ACLS is high profile training. So anybody that works in the hospital that's on a cardiac unit or in the ICU needs to be ACLS certified. This is most of the patients that work in the ER and ICU get called to the units if there's a rapid response team or there's a code. So some of you guys that have been in SIC or Boardman or St. Joe's, they might say, hey, we have a rapid response team. And one of the ICU nurses goes, because it might be on a floor where maybe the nurses aren't ACLS certified and they're not sure how to mix drugs and give things appropriately. So maybe some of you guys have even got to go to a rapid response team or a code where you actually go and you see the critical care nurse that's specially trained that can help give meds and help that nurse that maybe doesn't have that much experience with those things. It's a team approach, so we have to communicate very well. Usually it's teaching us how to, those of you guys that were on PCC with me on Wednesday, there was a guy that went hypoglycemic, and you can see everybody comes in, they have their role. Can you give me the vitals? What's the pulse ox? What was the blood sugar? You have somebody that's kind of running the scenario. And then don't forget that we can always call a code blue. We're thinking about all of our life-saving measures. So what drugs do we give? Do we have an airway? What kind of dysrhythmia are we in? If anything, do we need to do CPR? Do we need to pace the patient? Do we need to defibrillate the patient? Okay, that's antidysrhymics. Questions? Silence means we'll move on. Pulmonary edema. You can have cardiac or non-cardiac pulmonary edema, rapid fluid accumulation within the lungs. Usually it's advanced heart failure. So maybe the patient was already in heart failure and something has rapidly made the heart failure worse. Either the heart gave out or we gave them certain kind of medications or they had an MI. They can have valvular disease, of course, acute MI, I just said that. Flash pulmonary edema, pink frothy sputum. That's a hallmark characteristic. These patients end up in an S3, flushing in, flushing in, flushing in, flushing in. Of course, they're tachycardic, right? Everybody that has a gas exchange problem is tachycardic. They might have an elevated blood pressure. They're in respiratory distress. Boom, they got to sit up, orthopnea, right? They have rales or diminished, right? They're anxious. They're so anxious because they feel like they can't breathe. And remember when we talked about the difference between hypercapnia and hypoxia? Hypoxia, they're air hungry. They're looking for the oxygen. So they're like, I can't catch my breath. I can't catch my breath. And they're coughing up this pink frothy sputum. So respiratory distress, we're going to see a pro BNP greater than 450 because they're in heart failure. So what do we do for these patients? Well, vitals, never again before in our life will we ever forget vitals. EKG, chest x-ray. We might have to get gases and see if they're in respiratory acidosis. Do we need to get an echo to see how the blood is flowing through the heart and how well the heart is contracting and what our ejection fraction is? Cardiac labs. So are we looking for our troponin? Are we looking for the BNP? Do they have an MI? We need to do a transesophageal echocardiogram to look at the backside of the heart. What's our treatment? Well, the heart is failing and we've got fluid everywhere. So we have to decrease preload and afterload. What does that very well? Nitroglycerin. It works on the arteries and the veins. And then we have to improve cardiac contractility. Why? Well, the pump is broke. They went into rapid heart failure. So you can give these dilators on the front, like the heart's here, and you can give a dilator for the preload and the afterload. But if you don't fix the pump, you don't fix the problem. So we've got to fix contractility and fix the pump. And then we've got to dilate and we've got to decrease the preload so we're not overfilling the heart. And we have to decrease afterload so we're not pumping against a high pressure, right? So what do we tell our patients to do? Sit up. Vital signs every 15 minutes. Do we have to provide an airway? Let's monitor our eyes and nose. If we're giving diuretics, which diuretics help reduce preload, do we use diuretics all the time in heart failure? Of course. We can give oxygen. We give our loop diuretics, vasodilators. We love nitro, inotropes. Let's give some dopamine or Dobutrax, right? ACE inhibitors reduce afterload. Do we have to give beta blockers to reduce the myocardial oxygen demand? And remember, we can use Entresto. It's a new drug. You have to have a GFR greater than 30, systolic blood pressure greater than 100, but it works. So think about ACE inhibitors that convert that prevent angiotensin 1 from converting to angiotensin 2. ARBs work from converting angiotensin 2 to aldosterone. And this Entresto uses a combination of medications to kind of work the same way, that even a little bit better than we would say an ACE inhibitor and ARB work. So sometimes we use Entresto. So bottom line, your patient's anxious, they're hypoxic, they have rales, they have diminished breath sounds, and they are hypoxic. So we've got to get the pump working. We've got to dilate preload, dilate afterload, get rid of the fluid, and help them with their gas exchange. That's pulmonary edema. Questions? Okay. Moving right along then. All right, let's do aneurysms next. What else do we have today? Oh, pacing. Okay. So let's do our aneurysms. So I kind of have these broken down by like abdominal and thoracic. So if you guys look here, abdominal is the majority of aneurysms. And then, you guys know an aneurysm is like a weakening of a wall or a blood vessel. Okay. Highlighted: tobacco, hypertension, elevated hyperlipidemia are major risk factors. Okay. And you can see it, like, if you look here, abdominal signs and symptoms, thoracic signs and symptoms. What do we worry about down here if we have a thoracic rupture? What do we worry about down here if we have an aortic rupture? But look at here in the middle. The causes are the same for both. The treatments, are very often the same. So I kind of have the treatments kind of together, lumped together, and I've segregated some of it by TAA or AAA so that you can see specifically, but a lot of the treatments are the same. Okay, so it's kind of like, this is the pathway for abdominal over here on the left. This is the pathway for thoracic on the right. And then, kind of this is a combination here in the middle. Okay, so causes atherosclerosis. We have the buildup of plaque in the arteries, maybe some kind of congenital malformation, maybe some kind of trauma, abdominal trauma or chest trauma. They can have a pseudoaneurysm, infection, or pregnancy, cocaine use. But the major risk factors: tobacco, hypertension, and elevated lipids. Okay, so abdominal, we have to take them for surgery, or we're really concerned greater than 6. Thoracic, greater than 7. Okay. Let's see. We have to make sure that we auscultate for a bruit. And you guys remember in 110, we always talked about never palpate a pulsation in the abdomen. This is why you can actually palpate and rupture the abdominal aortic aneurysm. Even in the hospital, if you have somebody that has an abdominal aortic aneurysm that ruptures, only 50% of the patients make it. That is how quickly they bleed out. If they're outside of the hospital, the chance of them making it is very slim. Okay, so that's why we don't palpate. Thoracic, this is the thoracic aneurysm coming off of the aorta. So the aorta valve is right here. This is the aorta that comes up and off, and it'll come down and come through to the abdomen. And then there are the 3 branches at the top that help perfuse the upper organs, the brain, the heart, and the thoracic organs. Okay, so you can have an ascending, transverse, or on the arch, or descending. Okay, so they can have an ascending, which is coming up away from the left ventricle. Your arch or your transcending is here at the top, and then your descending is making this loop kind of heading down towards the abdomen. Okay, so what are your signs and symptoms? Well, think about where those areas, if you have an aneurysm that ruptures or that you don't have good blood flow, where does that part of the aorta take the blood to? So if you think about thoracic, they might not have any pain. If anything, they might have back pain or chest pain, because we think about perfusing those thoracic organs. Shortness of breath, they might be hoarse, they might have trouble swallowing, because remember, we're perfusing some of the throat and the organs in the neck and the brain. They might have some edema and in the chest or the neck. And then don't forget about your cervical chain. They might have some unequal pupils, because we're changing the way that the blood might be flowing to the brain. Okay, if we talk about an abdominal, we go over here, signs and symptoms, maybe none, right? So a lot of times we pick up these aneurysms on a regular CAT scan. They might have come into the hospital because they were having chest pain, or we were concerned about their lungs, and we do a CAT scan and we're like, oh, we have a thoracic aneurysm. Or we have somebody that comes in with abdominal pain or trouble moving their bowels or something GI related. We do a CAT scan and we're like, oh crap, we have an abdominal aneurysm. So a lot of times they're picked up by coincidence. Again, never palpate, maybe have some symptoms, if any, abdominal, flank, back pain. Sometimes it's like a gnawing pain. Anybody that comes into the emergency room that's in their 50s, 60s, or 70s that has this gnawing pain in the abdomen that radiates through to the back, and it feels like it's a ripping, tearing pain, gets a CAT scan no matter what. Let's see. And sometimes this rupture can take hours to days for it to actually, so if it takes longer, the patient has more chance of making it to the hospital. If it ruptures rapidly, then there's a really slim chance that they're going to make it. So let's go back to thoracic. If it ruptures, we have to worry about hypovolemic shock. They have sudden, terrible back pain and chest pain. It's lethal. If either one of these ruptures, it's lethal, because the aorta is the biggest artery in your body, and it takes away cardiac output. So it just starts leaking the blood into the chest cavity or into the abdominal cavity. They become tachycardic. They have a gas exchange issue, right? They sweat, sudden pain. The blood pressure will differ because of the subclavian artery. So you'll see a different blood pressure on the left than the right. Sometimes we work them up for an MI first, because the chest pain mimics an MI. Okay. If the abdomen ruptures, we have no distal pulses, right? So now we're in the abdomen, and that aorta takes blood to the renal arteries, the iliac arteries, and the femoral arteries. Well, now we've changed the blood flow to that area. So you might lose pulses. You might have no urine output or be oliguric. We might have, because of the decreased cardiac output and perfusion, we might have a change in mentation status. And these patients have that sudden radiating pain that feels like a ripping pain through to the back, and it can actually radiate to the groin or the penis in a male. Diagnostically, sometimes we do an ultrasound or a CAT scan, especially if let's say the aneurysm is 5 and we're waiting because they don't require surgery until 6. We might do routine or serial CAT scans every 6 to 12 months. Sometimes they have an eggshell appearance on the X-ray, when they do an X-ray on the patient. But here's the thing: we have limited diagnostic tests when they're dissecting, because it's an emergency. We're not going to send our patient to CAT scan if we know that they have a history of an aneurysm and they're having those classics, they might not make it. We might have to just go straight to OR and do an open belly and see what's going on. Okay. So what's our treatment then? Okay, so let's talk about treatment. So if they rupture, large IV fluids. I mean, we're running has anybody seen the rapid infuser? Maybe in the ER, you guys have seen it. Has anybody seen it in SIC?
Yeah, it's like a huge box on the IV pool.
Yep. Yep. And they literally, when we run these rapid infusers, a lot of times it'll be a trauma that will come in and then they'll get bumped over to SIC if that's where I've seen it most frequently, but I'm sure they use them a lot in the ER. They literally can throw a bag of fluid, a liter of fluid in 1 to 2 minutes, a bag of blood in 1 to 2 minutes. And you literally have one nurse running the rapid infuser, checking bags of blood. Like I would check a bag of blood with you. We double cosine off, scan, 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 up it would go. I'd back it up with a bag of liter of fluid. We'd be checking the next bag of blood because we know that the next one's going in that fast. So large IV sites, we need to make sure we have good IV sites. We need to make sure that we can get this blood and fluid in fast, because as fast as it's going in, it's going to be coming out. And we need to make sure we maintain gas exchange, hemodynamic stability until we can get them to OR. Okay. If they're less than 6 with the AAA, we do serial CAT scans. We want to keep the blood pressure between 90 and 120. We want them to stop smoking. We want to decrease their lipids. We might use calcium channel blockers or beta blockers to decrease the blood pressure, because if the wall of the vessel is weak, do we want a high blood pressure? No. The higher the blood pressure, which we know contributes to the aortic aneurysm anyways, the higher the blood pressure, the more likely they are to rupture. So it's lower blood pressure. Calcium channel blockers work really well. Beta blockers work really well to decrease that pressure. We can actually resect the AAA or do a graft. If that's the case, we have to bowel prep them. We have to think about pulmonary hygiene for patients. If they have a AAA resection, we have to, after they have a graft or a resection of that aneurysm, will we graft it or we stent it? If you think about the abdominal aortic aneurysm, what are we worried about? Well, perfusion off of that abdominal aorta. So what is our urine output? We're measuring I's and O's. We need to be checking the pulses, right? Make sure that we have pedal pulses and blood is flowing off of that aorta very well. We want to keep the head of the bed less than 45 degrees. We do not want them sitting in a high upright position because we need to maintain that good graft at a level that it can start to heal. So post-operatively, if they have an abdominal aortic aneurysm resection or stent, we're looking for an MI afterwards. Are they short of breath, chest pain, or dyspneic? We're looking for dysrhythmias. We've got to make sure we don't go into renal failure. If that graft or stent decreases the perfusion to the kidneys, we can send them an acute kidney failure. You guys have all seen that this semester. And then possible infection or impotence in a male. A lot of these patients come out with NG tubes and they have, their incisions are like from the chest all the way down to the pubic symphysis. Our major thing though is we want to make sure because they're going to have swelling because they're all the surgery in the abdomen. We want to make sure that they don't have abdominal distension. So we're going to use laxatives or stool softeners afterwards to make sure that that bowel gets moving. We have the NG tube to decrease the abdominal distension and decompress the GI tract. If they have a transthoracic aneurysm, so this is the one up in the chest, and we're going to do a graft or a stent, post-operatively, we're looking for ischemic colitis, right? That remember the colon, the upper colon or the small bowel is fed from the blood that's in the upper part of the body, that thoracic arch, all the blood coming off of there. So if we don't have blood circulating off of there very well, could we end up with not perfusing our small bowel very well? Are they not up moving around? And now we have like a bowel obstruction. They can hemorrhage, and then we have to think about perfusion to the spinal cord. So what would your patients look like if we didn't have perfusion to the spinal cord? Would they have some kind of numbness or tingling or difficulty moving extremities? Respiratory wise, we're perfusing our lungs off of that arch. And then we might have to check our chest tubes. You guys remember Mrs. Phillips talking about chest tubes post-operatively, because now we're in the chest. And unlike the abdomen where you have room for distension, you don't have room for that in the chest, right? Because remember, it's encased in a cage. So if I have bleeding into my thoracic cavity, anytime you do surgery in the thoracic cavity, there's going to be blood and fluid that collect in that cavity. We need to have a chest tube to remove that so that we don't impair or tamponade our organs in that chest cavity. That's aneurysms. I put some discharge instructions up here for you guys at the top.
So
have a
Jill,
question.
what would be the difference between dissection and rupturing?
Dissection is when it starts to leak. Rupture is when the vessel gives way. It starts to dissect. So because remember, it says it can happen hours over days. Dissecting means it's starting to give way and it's starting to leak. When it ruptures, it's gone. It's opened.
Okay, thank you.
Sure.
With a thoracic aneurysm, and you have ascending, transverse, arch, and descending, does it like is one worse than the other, or it just okay?
The treatment would be the same and the worry would be the same for all three
Okay.
areas of the arch. Yep.
Okay.
All right. Any other questions? Otherwise, I'll go ahead right on to our pacers and AICDs and our other hodgepodge of cardiac interventions. So if we talk about pacing, right? If we talk about pacing the patient, well, why would we need to pace our patient? Well, think about your heart blocks, right? We just talked about them the other day or our last review. And what was one of the interventions for every single heart block? We might have to pace the patient. So if they go in a first degree and they're symptomatic, we might have to insert a permanent pacemaker. If they go into a second degree type 1 and they're symptomatic, or a second degree type 2, we might have to do a transvenous pacemaker, right? If they go into a third degree, we're transcutaneous pacing them. Some of you guys were able to see patients post-operatively on PCC, and they had epicardial lead wires actually through the skin after open heart surgery, right? We might have had to hook them to the pacer box. Okay, so we might be pacing them after surgery and they don't have a permanent pacemaker in yet. We're not transcutaneous, but they're mediastinal pacer wires that actually are attached to the myocardium and they're pulled out through the wall by the chest tubes. And then this way we can hook them to a pacer box until that heart is able to recover a little bit more after open heart surgery or after they have an MI, right? So pacing, okay, so just a reminder, SA node starts conduction, heart rate is usually 60 to 90, AV node, if it doesn't fire through the SA node and it fires at the AV node, we're looking at a heart rate of 40 to 60, right? We're already starting at a heart rate that's slow. So why do we pace? Well, for bradydysrhythmias, tachydysrhythmias, so sometimes if you have somebody that goes into like AFib RVR, the electrophysiologist can actually pace them. They could start pacing that fast heart rate, and then the pacemaker starts to slow the heart rate down, and it tries to control and take over that fast heart rate and slow it down. We use it for sick sinus syndrome, where the patients might not have that SA node fire, or asystole. Remember, we talked about that last week. We talked about asystole and possibly pacing patients. Okay. So temporary pacemakers, transvenous. This is invasive. You're going in through the femoral vein. You're going up into the heart and the myocardium, and you're actually attaching the wires to the myocardium through the vein. So these patients have to lay in bed. They have to keep their legs straight. This is just temporary until we can get them stable enough to get them to have a permanent pacemaker placed. Transcutaneous is not invasive because we're just shocking them through the skin. We're pacing through the skin, but the patient hates it. We're using the patches, right? So now it's like bing, bing, shock, 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 right? So can you imagine having something like shock you? Think about like, even if you just get like, you ever shock each other, like it's dry and you get the static electricity and you're like, oh, that kind of hurt. Imagine that happening to your skin every so many seconds. So usually we use this in an emergency, always a third degree heart block. If the patient's symptomatic, this is our emergency intervention for that third degree heart block, but it's only temporary until we can get the patient scheduled for either transvenous or get them scheduled for a permanent pacemaker. If we have epicardial, okay, so epicardial is also temporary, but we have epicardial, this comes through the chest after open heart surgery, right? So it comes out through the chest. And if you have this transvenous, which we have the pacer wires coming out through the groin, or epicardial coming out through the chest, and your patient needs paced, we're going to hook them to a pacer box. And you guys got to see that, some of you on PCC, where they're hooked to the pacer box. We choose the rate, so heart rate of 60, 70, whatever the provider orders. And then you'll see a VMA and an AMA that actually gives the voltage to make sure that we're sensing and capturing appropriately. Here's some rules. If they have transvenous pacer wires or epicardial pacer wires, we must secure, this is so important, We must secure each wire with rubber, okay? Because why? Rubber prevents electricity. So if you take those rubber stoppers off and you yourself have static electricity and touch that wire, you're going to shock the patient's heart. If you allow the wires to bang together without those rubber stoppers on, you're going to shock the patient's heart. So you must always have gloves on when you handle the wires. They must always be insulated with rubber. If you lose one of the rubber stoppers, you can actually use a glove to insulate it. And they must be insulated before they tape them to the chest wall. You would never secure the pacer wires to the client's gown. Somebody comes in to change the gown, bing, there goes the wires, right? So they must be insulated, then taped to the patient's chest wall if they're not in use. Otherwise, they're going to be hooked to the pacer box, and the pacer box is going to be pacing them. Okay, so super important. After open heart surgery, if they do not need these any longer, we don't go back in and take them out. They just cut them at the skin. And once you remove the electrical portion of it, like when you cut the strings at the skin and you remove the metal electrical portion at the end, it can no longer shock the patient. So it's too risky to go back in and detach them from the myocardium. They just let them go. Okay, so if we talk about pacing, okay, the pacemaker, we need to synchronize with the patient's normal heart rate. If we try to pace in the patient's conduction that's already happening, we can actually make them asystole and stop their normal conduction from the SA or the AV node. Asynchronous is when you have somebody that's asystole. You're not waiting for the patient to have their normal conduction. They don't have it. So asynchronous is the pacer just beats whenever when they are set to beat, because the heart will not beat on its own. If you have somebody in an asynchronous mode, meaning it's just going to beat no matter what, and it's not following the patient's normal rhythm pattern, they can actually have what's on an R-on-T phenomenon, meaning the patient can actually pace and try to conduct or depolarize in the middle of ventricular repolarization, and they can actually make them asystole. So you have to be super careful. You as the nurse would never decide if they need to be in a synchronous mode or an asynchronous mode. That would be ordered by the provider. However, you're going to look for those pacer spikes when you're looking at your rhythm strips. Some of you guys, we had somebody AV pacing, so I got to show you a couple of strips this past weekend or this past week. You're looking to see, do you have an atrial depolarization spike and then a P wave that follows it, and then a ventricle depolarization spike, and then a QRS that follows it? That's how pacing should work. If you see a pacer spike in the middle of a QRS or a T wave, then it's actually not sensing or capturing appropriately. We'll talk about that here in a minute. Okay. So let's talk about complications of these pacers. Okay. So failure to capture means you'll see a spike with no QRS. Okay. So what'll happen is you'll see your normal PQRST. Okay. And then you'll see the pacemaker will sense that there's a pause and that you need a conduction. You'll see the pacer spike, but there's no QRS to follow it. Okay, so there'll be a pacer spike with no QRS. Well, what's our problem? Does anyone know what the problem is there? Failure to capture.
It's not working, right?
It's not working, but why? What's the problem? How do we fix this? If you were the nurse, how would you fix this?
You'd check your connections and increase your increase the pulse it's given, the milliamps.
You got to shock that shit harder, right? For lack of better terms. You got to increase the electricity because it's sensing appropriately. It knows that you need the QRS, but it's not delivering enough electricity to cause that ventricle to depolarize and repolarize. So you have to check your connections, check your voltage, and you might have to turn up the voltage. Okay. Failure to sense is when you see a spike in the middle of a QRS. So the pacemaker, even though your heart is going P, QRS, T, the pacemaker doesn't sense that you're depolarizing. Okay, it doesn't sense that you're depolarizing. So you'll have a failure to sense, and it'll spike or try to cause conduction in the middle of when the heart's already conducting. So how do we fix that? Well, we have to turn up the sensitivity. So we have to turn up the sensitivity because maybe it's not sensing when it should be sensing. So the sensitivity is down.
Does failure to sense work with the synchronous mode because it's paying attention to the patient?
Yes.
Okay.
It doesn't matter in asynchronous, but in yes, absolutely. If you're over spiking or over sensing, that means that there's no spike on the QRS when there should, or on the line when there should be. So you'll have a pause and you're like, hello, pacer, where are you? There's this pause and we expect that the pacer should kick in and should cause a spike with a QRST, right? So what happens is you're over sensing. So the pacer senses that there's actually stuff happening on that isoelectric line when it's not. So it's like, oh, and the line might look like this. And it's like, oh, the ventricle is contracting when it's really not. So in that case, you just have to turn down the sensitivity. So we'll actually sense that there's no conduction in the ventricle and pick up and spike that ventricle, shock the ventricle. Okay, so those are complications. So you as the nurse aren't going to set these settings, but you need to know to look for them. You need to make sure that that pacer spike is happening in the right place. You must make sure that when you see the pacer spike, it's either followed by a P wave or followed by a QRS, right? Or we're not having long pauses. We're out with the pacers not actually kicking in when it should be, because then we have to make sure that we adjust the pacer box. If they have a permanent pacemaker, then that means we have to call the provider and say, hey, listen, this pacemaker is not working. It's not sensing when it should be, or it's not capturing it when it should be, or it's over sensing, right? If the patient goes for a permanent pacemaker, right, they're usually put into a pocket up here in the chest. So we have to look for a hematoma at the site. I've seen it. Usually they come back from the EP lab, which is where it's inserted, with like a sterile dressing and maybe a sandbag, like a 3 to 5 pound sandbag over the site to prevent a hematoma from developing. They can actually go into tamponade. Maybe the lead perforates. This actually happened to a patient of mine one time. The patient came back from a pacemaker and he got kind of confused. I'm like, something's not right. He was an older gentleman, but he wasn't confused before he went. And here he actually, when they went in and did this procedure, he actually caused him to have a pneumothorax. The lead perforated the wall of the lung whenever they were doing the procedure. I'm not sure how it triggered it. And the patient ended up having a pneumothorax, and they started going to AFib RVR because now they had a drop lung. We had a gas exchange problem. We were worried about a tension pneumothorax. So this patient emergently got a chest tube. Okay. But this patient never had a history of AFib, and I'm like, something's not right. So when I went to listen to the lungs, I had no lung sounds over the side where the pacemaker was placed. And I'm like, they dropped this guy's lung. So they can go into cardiac tamponade. They can perforate, and now we can have blood accumulating in that pericardial sac because of the lead part, and it constricts the cardiac tissue, so it's no longer able to expand. So it causes like a tourniquet around the heart. So you'll see an increase in the right atrial pressure because all this blood is backing up and it's trying to fill the heart. And you'll see an increase in the CVP, but a decreased cardiac output because we're not able to fill that left ventricle. So we have a high filling pressure, but we're not actually filling the chambers of the heart. Okay, so major complications you have to look at. If they get a pacemaker, post-operatively, if they have one, they're going to wear a sling for 24 hours. Okay, we want to keep this close to their arm, close to their body. We don't want the arm out and away and up. Okay, we have to know the settings, right? If they should be pacing at a rate of 60, you as the nurse better make sure that they're pacing at a rate of 60. Even though you might not be able to change it, you got to notify the provider if you see something different. We always do a chest x-ray to rule out a pneumothorax. Obviously, I just told you that was the case with my patient. We should be checking vital signs. We're looking for signs and symptoms of an infection or hematoma, and we have to put them on a monitor for at least a short time to make sure that they're capturing and sensing appropriately with that new pacemaker. When they go home, they should not be lifting more than 10 pounds. They should not put their arm up over their head, and they shouldn't be driving. We need to make sure that their cardiac output's okay and this pacemaker is working. If they drive and the pacemaker is not working very well, they can end up bradycardic and pass out and get in an accident, right? If they move their arm up over their head or way out away from their body, they can dislodge those leads. So when we initially put them in, they're sutured to the atria or the ventricle, wherever we're expecting to pace the patient. But we have to, after a while, the muscle, just like if you had a suture in your skin, it would start to heal around the suture. Well, we have to let the same thing happen to that muscle. We have to allow the suture to heal into the muscle so that we can actually cause conduction with the electricity. Let's see. AICD is sometimes you might have a patient that has a pacemaker, which we use for bradycardias and sometimes tachydysrhythmias, but heart blocks, spinal branch blocks, asystole. And AICD is used for somebody that goes into VFib or VTAC, and we need to defibrillate them. You might have a patient that has an AICD and a pacemaker in one device. So it might pace the patient, but if they would go into VFib or VTAC, it would also shock the patient. Usually the AICDs are used for patients that go and have an MI or really overly distended hypertrophic muscle or heart failure and the ejection fraction is less than 35. Let's see. This, I already talked about firing with VFib, VTAC. So some of them can sense, pace, and shock if it malfunctions. This is really important because I've actually had to do this on a patient before, and you guys might have seen this in the emergency room. If your patient has a AICD that fires, okay, if they have an AICD that fires, they need to go to the hospital because we need to figure out why is the AICD firing, right? Is it firing because they have an electrolyte abnormality, right? And we need to correct their electrolytes. Do they have an MI and they didn't know it? So now we have to look and see why, why we have to work them up for an MI. So anytime it shocks, they should go to the emergency room, call their electrophysiologist. But what if the pacemaker, or I'm sorry, the AICD malfunctions, right? And now it's shocking and everything else is okay with the patient. We need to demagnify that. Okay. So we put a magnet, we keep a magnet on every unit on the fridge and usually in the med room so that we can go in and take the magnet and we put it over the patient's AICD or pacemaker, and it demagnetizes it, it shuts it off. However, you better be prepared to back up pace or back up shock the patient. Once you shut down this device, you can't reactivate it. So you need to make sure that when you shut this off, you already have the wires and everything paced to the patient so that you can provide backup shocking or pacing if needed to the patient. Okay. This is why they're not allowed to go for an MRI, because it's an MRI, it's a magnet. It's going to shut off the pacemaker, the AICD. They have to be super careful about going through any kind of electronic device. If you go to like any hospital or security at the airport, right, you'll see that they have multiple machines and some of them are magnetized. So if you have a pacer AICD, you cannot go through certain machines. You might have to go and be wanded or go through a special machine that won't demagnetize the device. They should be super careful about putting these cell phones are like mini computers, right? So super careful about putting a cell phone over that. They used to say like microwaves or devices that have a magnetizing thing at home. I don't know. We don't like use gaming devices at our house. Like my kids don't play video games, but like anything like that, that would be electronic or a new device. We have to find out if it has a magnetizing agent to it because it should stay away from that patient's pacemaker or AICD. If you have to shut off your patient's AICD and they go into VFib, you've got to put the pads on the patient now and defibrillate them. If you shut off their AICD and their pacemaker and they go asystole, you now have to pace the patient. Okay, so you have to be the pacemaker if you shut it off. So just please remember that because now they do not have that backup device. Post arrest, she talks about this a little bit, so I just wanted to kind of mention it. Post arrest, if they have go into cardiac arrest or a massive MI, we have to talk about target temperature management. So we rewarm consistently, but we like the body to be cool. So when you work in the OR, a lot of the rooms are super cool, decreases the metabolic demands of the body. Usually we only do this in the hospital. We want to avoid shivering. If the patient would shiver, we would give Demerol. That's the drug that we use to stop shivering. But we found out that the longer, and we do this with neuro patients too. If you guys have seen, how many of you guys in SIC have seen the patient butt naked, especially traumatic brain injury, with just a sheet over them? Anyone?
Yep.
Yes.
Not traumatic brain injury, but the guy that I just had in SIC the other day had just a towel over his groin. That's it.
So was he a neuro patient?
No, not really.
Okay.
No.
So a lot of times with the neuro patient, because we're trying to preserve the cerebral cells, or a heart patient, we're trying to preserve those myocardial cells. We do target temperature management and we try to prevent the patient from being hyperthermic or hypothermic. And we try to slowly, we cool them down, which kind of decreases the metabolic demands of the body. And we slowly rewarm them because we want to give their tissue a chance to heal. Okay. So something that we might see post-arrest, the intra-aortic balloon pump, we talked about that. It decreases afterload. So if you have somebody that goes in, that has an MI or goes into, has cardiomyopathy and goes into flash pulmonary edema or major heart failure, and that we have a high afterload, that's hard for that heart to pump against, right? So we have to make sure that we we can use the intra-aortic balloon pump, and it works opposite of the ventricle, right? So here's your pump. And remember, Mrs. Phillips is like, I mean, it's a huge catheter, right? So this is the ventricle pumps, the balloon's deflated. When the ventricle relaxes, the balloon inflates and forwardly advances the blood. So they work opposite each other. So it's cracked like this, okay? And it forwardly advances the blood, so it decreases the afterload. But it goes in through the groin. So you have to be thinking about your 6P assessment on that side. What are your pedal pulses? If you have that balloon pump in there, we have to make sure it doesn't go up too far and block the blood flow off the aortic arch, or slide down and block the blood flow off the abdominal aorta. And that might decrease the blood flow to the femoral pulses, or decrease the blood flow to the renal artery or through the renal arteries. So you might see a change in urine output or change in your pedal pulses. Those assessments are extremely important. Lastly, she talks about a couple other like devices, like if you put your patient on the heart-lung machine, like ECMO, we have to worry about bleeding. We put those patients, I mean, hot, like, has anybody taken care of anybody with on ECMO in the ICU yet?
No, a few of us got to see someone though.
Okay, so you got to see him when you were over there? Did they take you over to like CBIC or something?
Yeah, they let us go in his room, and they like all the big machinery. He had like 4 IV pulls, and those tubes are like giant.
Right? They're like garden hoses coming out of the patient. So do not do anything that would dislodge that hose, because if you do, the patient will bleed out and die immediately. It literally takes all of the blood out of the patient's body and takes it to a machine, which gas exchange occurs, and then it puts it back into the body to perfuse the tissues, right? And it's because either the lungs are so sick, like in ARDS and COVID patients, we're seeing this, or the heart is so sick, or both. So it's basically the same machine that they use for open heart surgery, where they take the blood out of the body, they promote gas exchange, and then they put the blood back in the body because the heart and lungs aren't working well together. But anytime you take the blood out of the body, it's high risk for clotting. So these patients are on super high doses of heparin, and you have to really worry about bleeding, right? Same thing if you have somebody that has the ecosystem and they use it to break open a pulmonary embolism, we have to worry about bleeding. So just a couple things to think about when you're using those devices. While we're thinking about clotting and bleeding, we're using a lot of heparin. I mean, higher than you would ever give for like a PE. High doses. I mean, they follow a totally different algorithm. So these patients are high risk for bleeding out. That's all I got.
No, I have a couple questions about the pacing,
Mhm.
if you don't mind. Okay.
No, yeah, that's why I'm here.
So like the asystole, because to me, asystole is like flatline dead. Like, and I didn't think that you could defibrillate asystole. So how can we pace it if there's no electrical activity?
So so the pacemaker is the electrical activity. So if you have somebody that has like a 6 sinus syndrome that we know,
What is that, by the way? Because you keep mentioning the SSS and I don't recall 6 sinus syndrome.
It's just where there's a disease of the conduction system where the SA node doesn't fire the way it's supposed to, because the SA node should fire.
Yeah.
So sometimes patients have this. It's almost, I don't want to say it's genetic, but sometimes we know this early on in life that they have like a 6 sinus syndrome where their SA node doesn't fire the way it should be. So if they have that, then we know for sure they're going to need a pacemaker, or eventually they would end up asystole. So anybody that has a rhythm or even a failing heart because of age, one of the number one reasons that patients need a pacemaker is just their heart is failing because they're older. It's been working for 85 years and it's tired. It's a muscle and it's tired. So once we can start to get some electrical activity back, and I don't mean by defibrillation or cardioversion, I mean once we can see that there's some electricity back in the heart, we can actually start pacing them. Or if we know that if we didn't pace them, they would be asystole, that would be why we would use the pacemaker.
Okay. You answered both of my questions in one statement. So thanks.
Okay. I'm going to go ahead and stop sharing for a second and just stop the recording. So it's not too long. Let's go back to watch it.